Well, yeah, thanks for that very nice introduction, Andy. So yeah, I have like a attention span problem, and and a too many interests kind of problem that I think is common to a lot of us researchers. And I tend to get interested in pretty much anything that has to do with language. And so today's talk though is about reading, which I don't know whether it has anything to do with language or not. Like, so as Andy mentioned, I actually started as an undergrad in linguistics. And so I never really had any interest whatsoever in reading. I mean, I just thought, well, that's not language, you know? I mean, like, why would you study that? I mean, it's just some kind of pale reflection of language. And I wouldn't be surprised if many of you in the room kind of share that perspective. Not my fellow Aussie, of course. But I got kind of dragged into this line of work, like so many of those things that you mentioned. I was thinking of those papers and and the various sort of circuitous routes by which they came to be. But I got dragged into this stuff a few years ago, and I've actually ended up finding reading really interesting. And I'm talking about reading mostly at the single word level is what I'm going to talk about today. And so I'm going to talk about a couple of studies in collaboration with these people. And you guys may have seen these U of A folks, Paige Beeson, Kendall Rising, Steve Rapchak. And this guy, Matt Stibb, he was a undergrad who worked in my lab on the first paper I'm going to present. And then the second paper is with these people from UCSF, Mary Lou Guarno-Tempini, Simona Brambati, and Maya Henry. So these are the co-authors of these studies. And I'm going to talk about single word reading, the whole model of it in terms of the cognitive processes and the brain. Obviously, it's going to be fairly superficial given the scope. But I'm going to focus on what we've learned about the anatomy of single word reading based on progressive alexia. So progressive alexia, obviously, by kind of decoding the name, progressive means it's caused by a degenerative process. It's a reading deficit that gets worse and worse with time due to a disease of aging, and alexia means inability to read. So single word reading is sort of typically broken down into two major stages. There's kind of peripheral stages where you go from a pattern of light falling on the retina to some kind of abstract visual word form, and then there are central stages where you map from that word form to either a phonological representation or a semantic representation, and that's I know that's not really a depiction of those two things, but you've got to make your slides look nice. So I'm going to talk about the two studies I'm going to talk about basically are relating to these two different aspects of single word reading, and I'll do them in that order. So the first one is about peripheral processes. And so, what has to be solved by the brain here, right? We have to go from, what has to happen in peripheral reading is we have to solve this problem of invariance. We have to create an invariant representation of a word from an extremely variable set of possibilities as to what pattern of light falls on the retina. So for instance, we would like our peripheral reading mechanisms to develop invariance with respect to size, right? We can read things in different font sizes. It's not a problem. We can also read things in different fonts, and that's not a problem either. And I know that some of you guys have taken my class where I talk about this stuff, so you have to be quiet. Does anybody know what this font is? What is this font? Comic Sans. Yeah, I've ended friendships over people using this font in their slides. It's just like the worst font in the world. But we can read the word. We can read a word no matter what font it comes in, right? So we're able to correct for things like serifs and weird, fake handwriting, or we're also invariant with respect to location, right? It doesn't matter what place in the visual field the word falls. It can be mapped to that same central abstract representation. And we're also invariant to a large degree for rotation, right? So you can put your head on the, you can turn your head to the side and you can still read things just fine. Or I can show a word that's rotated and you can still read it just fine. We can even, read things that are really kind of a long way. That'll really give a lot of problem to on a computer trying to do OCR. We can do that. We have no problem with these. And the reason that I picked the word love in the first place was because I knew that I'd be able to find really corny, junky depictions of it on the internet without too much trouble to demonstrate just how far you can go from the simple text. So we have to solve this problem of invariance. Now, so if you have a peripheral, so then, when you have a deficit to different aspects of the reading process, it's called an alexia. Sometimes people use the term dyslexia. I mean, dyslexia often is used more in developmental contexts, whereas alexia is used in acquired contexts. But this is not completely always the case. And so if you specifically have a problem with these peripheral aspects, then you have what's called a peripheral alexia. And then you can have deficits in mapping visual inputs to visual word forms. And now I'm remembering that my talk has audio in it, and I never made any attempt to test that. So let's see how that goes. So this guy's going to read the word list. There's pseudo words, obviously. That's good. And it's silent because he's actually doing his best. That was the reaction time. That's like 11 seconds. It's kind of painfully slow, isn't it? But I have to get to the second part. So you see, he's not entirely accurate even when he does finally get it out. And this is a very intelligent man. I mean, he's highly educated. He has no major aphasia apart from this. Okay, so I don't even really need to explain what that, I hope that it's obvious what that shows. It shows the peripheral nature of the deficit, right? This is not a phonological deficit. If you give it to him in auditory form, he has no problem transcoding and like figuring out, what the orthographic to phonological transformation should be. It's like kind of on the input end. He can't turn that visual input into a central representation, or if he can, it's very slow and error prone. So this is a peripheral alexic, and they're really uncommon. But I'll tell you about the kind of studies that we did with him after I kind of go through a little bit more what's already known about the neural basis of these peripheral transformations from when light falls on the retina to an abstract word form. So this is the visual system, and this is like scanned in from my neuroanatomy coloring book that I used in grad school, and I've like painstakingly colored all this stuff in. As you can see, I do not go outside the lines at all. I'm not one of, I'm a very, there's different adjectives for what I am, but I'm the kind of person that doesn't go outside the lines. So what you see is the light basically falls on the retina. It crosses to the opposite, so the left visual field crosses to the right hemisphere, and the right visual field crosses to the left hemisphere from both eyes. And that's what you kind of see here. I'm not going to go through all the detail. And then it winds up in the back of the brain, upside down in the occipital cortex, and then the information kind of makes its way forward. Like there's a chain of processing that heads anteriorly from there. So the primary visual cortex is right at the back in the midline, and then it goes, in both hemispheres, it makes its way forward through a series of processing stages, which we actually understand really well because most of this stuff is in common with creatures that we have no compunction about, removing the skulls from and inserting electrodes into. So because visual processing is so highly preserved, we actually know a lot about it. So what happens as you go forward in this visual processing stream, two things happen. One, receptive fields get larger. So neurons in early visual stages are only sensitive to like a very small part of visual space, and the further forward you go, the bigger the receptive field goes. So that's kind of a depiction of that. The receptive field is just getting bigger and bigger. So as you go further forward, no longer do the neurons care about where something was in your visual field. They care about what it was. And so that's the other thing that happens in parallel, is the kind of information which neurons are sensitive to becomes more and more kind of high level and abstracted. So whereas, you know, the retina cares only about light, primary visual cortex starts to care about lines, you know, because the information basically has been combined from the previous level. It's like if you saw a pattern of light that was arranged like that, then hey, that's a line. So now I'm going to represent lines. That goes forward to shapes, and then further forward still, you know, you start getting from shapes into objects. So you kind of see this emerging pattern where there's this, you know, receptive fields become larger and larger, and the complexity of representations becomes larger and larger. So that's obviously nothing specific to language there. But the idea is, you know, that language, especially reading, right? We didn't have any time to evolve reading, so it's entirely built upon our existing visual system. Even if, I mean, you know, people obviously debate like to what extent that's true for all of language, and I certainly think that for the rest of language, like a lot of evolution must have taken place. But for reading, I don't think that we can really argue that it has. So basically, the existing visual system has to be exapted for reading, right? It has to be turned to a new purpose. And that's this model of reading from Dehaene and Cohen, who are these French guys that have done like a lot of the best work in this field. And basically their theory goes like this. So there's bilateral processing through those series of visual areas that I mentioned. So we're going from back of the brain forward. And then at some point, it actually all becomes left lateralized because, you know, language is left lateralized by and large. And there comes a point where the right hemisphere isn't that good at reading when left to its own devices. And so there comes a point in this processing stream where most of the information processing now happens in the left hemisphere. And you go further forward. So as you're going forward through this system, these are the ideas about what the features might look like that the neurons are sensitive to. So here, like I said, like in the thalamus, it's just like points of light, then it becomes lines, then it becomes like edges and corners. And then we might start getting letter shapes emerging, but still a capital E and a little e would look very different. And then somehow as you go further forward and things become increasingly abstracted, now we start to become sensitive to higher level kind of, you know, more abstract representations of the stimulus. So that's kind of the view of how that visual system that we share with other animals might get turned in service of reading. And so what's the evidence for that? Well, there's a bunch of like really good studies that have come out over the last 15 years that essentially show us the importance in particular of the most anterior part of that whole system. I'm just going to back up one slide. When we get here, people call this the visual word form area, and this is the area that becomes that is thought to encode those abstract visual word forms. And the evidence for that comes from a bunch of studies, mostly from Dehaene and Cohen and their colleagues. So, for instance, this is an fMRI study where participants saw these 4 types of stimuli, words, but they've kind of had the corners taken out to avoid giving, to make them easier to control, because then you can scramble it, right? So without the corners, with the corners, it becomes hard to create a true visual match. And then objects with the same thing, and then so this is like a really good, tight visual control condition. And, you know, apparently annex with an E on the end of it means something in French. I'm sure that there's at least somebody in the room that knows what that means. Probably annex. But like I said, these guys are French. So they compare that to that, and then they compare that difference to this difference. So they're making a map of areas where the signal is greater for this contrast than for that contrast. And the area that they find, well, that, I don't know what that is, that's nothing, because that's not what we would hypothesize. But that one there, that's the visual word form area. So as you can see, it's left lateralized, it's quite anterior. You know, we've gone quite a long way. It's like the sort of anterior terminus of this pathway of developing specialization. And here you can see how, like, the signal, as you move from posterior to anterior, for objects, it's no different in the left and right hemispheres. Whereas the right hemisphere basically doesn't show any selectivity. The left hemisphere kind of shows this emerging selectivity. And I'll show that in more detail in a moment. Okay, the next thing that Cohen and Dehaene showed, or actually an even earlier thing that they showed, was this invariance for location, right? So they flashed words to either the left visual field or the right visual field, and that's shown over here. And they found that regardless of which visual field you flash things to, you would activate this region in the left hemisphere, right? So you can see that the visual word form area is always in the left and not in the right, even though they're flashing the words to the left and right. And that's completely different from any other visual stimulus, right? Because any other visual stimulus, whatever field you flash it to, it's going to activate the opposite hemisphere. And it shows us that we're looking at like an abstract representation that's become invariant for location. This is another slide that I think kind of shows more clearly that gradient that I've been talking about. So here we've got a bunch of locations moving through the brain from posterior to anterior in both hemispheres. And here are the stimuli, and I don't know whether it's, I'm sorry, it's probably not that readable. Oh, I guess some people can probably read it. So it goes kind of from, the stimuli increasingly develop in their linguisticness. So it starts off with false font, which is, just, it looks like a font, but it isn't a font. Then it goes to pseudo words that are made up of infrequent letters, like J's and W's and Z's. Then it goes to pseudo words made up of frequent letters, and that includes Q, because these guys are French. Then it goes to pseudo words made of frequent bigrams. Finally, it goes to pseudo words made of frequent quadragrams, and finally it goes to actual words. So you kind of see this gradient of wordiness. And then if you look at the neural responses, these are those 6 conditions, moving from posterior to anterior. In the right hemisphere, you essentially see it doesn't care, it couldn't care less whether you're looking at a pseudo word or a word like mouton, which I believe means sheep, right? Whereas in the left hemisphere, if you're posterior, it doesn't care at all, like they'll all activate equally. But the more anterior you go, the more you start getting that emerging selectivity to the difference between words and false fonts and all the things that lie in between them. So that is to me like the cleanest, nicest kind of demonstration of their basic theory. And that's what we're going to look at in our patient in particular to understand what's going on. Okay, so I've been talking about all the ways in which the visual word form area is invariant, but there are limits to its invariance, and these are principled, right? So whereas with a normal visual stimulus, if I flip it, if I mirror image it, it's essentially, in most contexts, would be considered the same visual stimulus, more or less. That's not the case for a word, and we can see evidence for that in the neural signal. So this is an adaptation study where they show that for pictures, if you present the picture that's mirror imaged, basically that causes the same amount of adaptation as if you presented the same picture, whereas if you present a word that's mirror imaged, it's like it's seeing it for the first time. So it has, the visual word form area is not invariant to rotation for words, but it is for pictures, or all the surrounding areas are for pictures. Okay, so that's kind of the functional imaging evidence. There's also patient evidence dating way back to 1892. So Desjardins was one of the very first major, brain and language guys, and he observed a patient with pure alexia due to a lesion somewhere in the vicinity of the occipital lobe. And I don't want to get too much into the details. Like Desjardins thought that the visual word form area essentially was in the parietal lobe, and that somehow his lesion had interfered with the fibers that were going there. But more recently, the people have started to suppose that it was probably the lesion actually probably affected these fibers that were connecting visual regions to the visual word form area. This visual word form area, by the way, is way too lateral. It should really be there, and I don't know why they put it there, because this is the Dehane-Cohen group, and they know better. But this is like a simple modern study showing how lesions in this region cause pure alexia. So this is an overlay of the lesions of patients that had pure alexia, like the guy that we saw, essentially. And this is an overlay of patients that didn't have pure alexia, but they just had hemianopia, which means they lost one of their visual fields. And if you compare those two distributions, you get this kind of difference map showing the visual word form areas where having the lesion causes you to have pure alexia. I'm going to skip that one. Okay, so getting closer to our own study, it's also been recognized for about 25 years. And I have to keep, with these years, right, I'm sure that some of this happens for a lot of you, you have to keep calculating them again, like how far away they are. Because I keep on wanting to say things like, because I grew up in the early 80s, it's when I became sentient, I guess. And, I kind of sort of still imagine, the 70s as being 10 years ago. And I've sort of stuck with that ever since my childhood. And now in science, I started really being a scientist, I guess, in the late 90s, so I sort of sometimes think of stuff in the 90s as being new stuff. And now when I'm teaching, I always have to, okay, 25 years ago, this new study came out, and I'm not even, all that old yet. But anyway, 25 years ago, the progressive alexia is very rare, so there actually hasn't been a lot of studies on it. But this is one of the earlier ones. And this is a patient that one of the hallmarks of peripheral alexia in particular is that you get your reaction time for reading is a function of the number of letters in the word, right? Because you notice with that guy, he was kind of painstakingly going through letter by letter. So when you do that, your reading time linearly depends on the number of letters. And so that's what you see with this patient here. And then what this shows is, he's trying to copy this figure. I'm not sure if he's copying it directly or copying it from memory. I don't remember, but as you can see, he's got a much wider ranging kind of, he's got some serious visuospatial problems that go beyond language. And so it's not particularly a pure case of an alexia. And brain-wise, there's almost nothing known until the study I'm going to tell you about that we did. But you can see in this, and this is like a clinical study, so left is on the right and right is on the left. You can see how it's all the white stuff there? That's basically the cerebrospinal fluid filling sulci that are expanding. So that's basically a hallmark of degeneration. And so because the image is flipped, you're basically seeing left posterior degeneration. Left posterior, of course, makes a lot of sense with the imaging studies we've seen, but it's not very specific. But that's kind of what's essentially known about progressive peripheral alexias. Basically, like not very much behaviorally and definitely not very much brain-wise. So that was why we wanted to understand better what's going on in the brains of these patients and what it is that's abnormal that's making them into such profound alexics. And our hypothesis, simply enough, is that the visual word form system, and I say system, not area, so the entire kind of process leading up to that differentiated abstract representation, our hypothesis would be that in these patients it will be functionally abnormal even though there's not a direct lesion to the area like there would be in a stroke, right? So all these sort of classic lesions causing strokes, it's like, causing alexia, it's like you had a stroke or you had like a gunshot wound or a trauma. These patients, they're degenerative, so it's not like no brain region has disappeared, but just neurons are dying off and regions are kind of shrinking and becoming abnormal, and we don't really know how they're becoming abnormal. So that was our hypothesis, was we would see functional abnormalities even though we don't see a frank lesion like in a typical case. So this is actually our second patient. We have we worked with two patients, and I guess I'm going to omit, well, no, I'm going to play his video too. It's kind of different and complicated in ways that I'm not going to be able to explain, but I'm going to play it anyway.
Verse? I don't know, that's not it. Is it here? I'm going to spell this one. R-E-A-C-H. Reach. S-H-O-P-E. Sharp? No. Cough, C-O-U-F-D. Cough. That don't sound right. Cough, C-O-U, no, that's not C-O-C. H-O-I-R. Cough. No, C-O-U something. No. C-H-O-I-R.
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 Yeah, what do they call it?
This guy, he reported that his main reading material, and he wasn't like hyper educated like the other guy, but he read the Bible, so he didn't come up with quiet, but apparently they were good. But so you guys probably noticed. I mean, I find that last one fascinating because it's like he knows that it's one of these sort of hyper irregular words, but he's cough, and he's mixing cough up with choir, but he can't quite connect it. Now, I'm not purporting to have any explanation as to all of the phenomena that were going on there. There's obviously like a lot going on. There's like letter level stuff, there's like letters into words, and then there's weird semantic stuff as well. But, you know, overall, it's a pattern of peripheral alexia. He does a lot better if you give him in spoken language. Okay, so when we looked at these two guys, basically the first guy is not, this is just kind of a battery of aphasia tests, and I know it's tiny, I apologize for that, so I'll just summarize it in words. The first guy is really not aphasic at all. He has some naming problems. He's not a great namer. He got like 45 out of 50, but 45 out of 60, and the low end of normal is about 50, so you know he's only just a little bit below normal. The second guy, I would describe him as a logopenic primary progressive aphasic. So he has like some phonological problems in his language and some naming problems, but not severely aphasic. His alexia is far out of proportion to the rest of his language deficits. So we also quantified not just their general language functioning, but their visual spatial processing. And so this is, they see this figure, it's called a Ray Ostereth figure, and then they either have to copy it or they have to try and recall it after a delay. As you see, both of them do pretty well in the copy, although apparently somebody had had too much coffee, maybe both of them. And both of them did okay in the recall. You know, I mean, this is not a terribly easy thing. Like, you know, you show it to them, you don't tell them that they're going to see it again later. 10 minutes later, you're like, hey, that figure that you saw before, can you draw it for me again? And some people will draw something like that. But like, this is actually a pretty decent rendition, not knowing that you needed to remember it. So the visual spatial processing, unlike the literature patient that I showed you guys, is actually like really quite preserved. So especially in the first guy, you've got preserved language, preserved visuospatial, just really, really pure alexia. Second guy has some more language issues, but still pretty pure. The alexia was characterized. I'll just point out, for instance, oral reading of pseudo words. First guy, on his initial visit, he got 10 out of 20. On his second visit, 6 months later, he got 1 out of 20. So complete failure to read pseudo words. Second guy got 0 out of 20 on his only visit. But even on real words, they do pretty poorly. So in his first visit, first guy got about 56 out of 80. Second visit, he was down to 22 out of 80. So he's only reading like a small minority of words correctly. And the second guy had even more problems. So just kind of documenting that these patients are profoundly alexic. Okay, so now we turn to look and see what we can see in their brain that might explain why this is the case. And the first brain, so this is the first guy. I know that not that many of you guys look at a lot of brains, but this is a very normal looking brain. Like there's nothing visually abnormal about this brain. If you look closely, this is the left hemisphere and this is the right hemisphere, and what shows up black is cerebrospinal fluid filling in gaps and so when you get atrophy, you always get expanding CSF. So if you look closely, you can see that there's more atrophy on the left than the right, and that's always a hallmark of like progressive things that are going to affect language. But that's not anywhere in the vicinity of the reading system at all. That's frontal. We actually did see statistically that there was some atrophy in the visual word system. So that sulcus there that's kind of wider than that one turns out, to my great shock, to be statistically significant. But we never noticed this until we actually like ran quantitative analysis on this. There's no way that a radiologist would call this anything other than a normal brain. The second guy, on the other hand, he has like quite a lot of atrophy, and you can kind of see comparing the two of them. Look how much wider the sulci are, and so all of this is significant. And he's got he's definitely got atrophy in the visual word form system, but not really any more than he has in the rest of the brain, to be honest. I mean, it's a left lateralized pattern of atrophy, but it's nothing that would explain these symptoms. So we thought that, given that structural imaging essentially doesn't really explain it, we wanted to turn to function and see if we could look at the functionality of these regions and whether we could see evidence for dysfunction that might explain it. So we had people doing a really simple task where they would see blocks of words or blocks of false font strings or blocks of words, and it would kind of alternate back and forth between them. And their task was just to simply press a button whenever they saw a red one. So the task was completely orthogonal to what we were actually interested in, and they thought that they had to like respond really quickly when they saw the red one. and that turns out to be important because like if you let people focus too long, and we also present these things really quickly, so it's going on at 3 per second, like they're seeing these strings just flash up. It turns out if you do it slowly or you don't have a distracting task, people start like having thoughts about the stimuli, you know? Like, I wonder what they mean by strict Friday, you know? Is this like, are they testing to see whether I'm Catholic? Is that resume or resume, you know? I mean, oh, that's interesting. Is that Cyrillic? So you can stop all this stuff, though, by just presenting the stimuli fast enough and having a really hard, distracting task. When you do that, you can, by diverting conscious attention from the stimuli, you end up tapping in a much more consistent way into the unconscious processing differences between these. So that turned out to be the critical thing. Like, it wasn't until we played around with the stimuli for a bit that we were able to design a contrast basically between these two conditions that will really reliably identify that gradient that we wanted to see. So you guys are probably at least somewhat familiar with fMRI. The idea is you take multiple images really quickly while having the subjects engage in different conditions, and then you essentially see how blood flow changes between the conditions as an indirect measure of neural activity. So basically we're going to look for regions that are more active for words than for false font strings to map out the visual word system. Okay, so the first thing we looked at was just that visual word form area, which is that anterior part of the process which distinguishes between words and false fonts, or even between words and non-words. And what we found in every single one of we had 10 controls and our 2 alexic guys, and every single one of the 10 controls showed a nice visual word form area. So I'm just showing 3 of them here. Here's 1, here's 2, and here's 3. So we could see that consistently, and like I was saying, to see that consistently, we needed to really optimize the parameters. Here's, and then here's our 2 patients. And normally, in functional imaging, when you get a blank brain, it's devastating, right, Julia? It's like you tried so hard to set up some contrast to show something that was going to be really interesting, and it's like the brain doesn't care about what you did. Like, as far as the brain's concerned, those 2 things are equal. That's what we're seeing here for these 2 progressive alexic patients. As far as their brains are concerned, the real word blocks and the false font blocks are the same thing. So that's kind of interesting, because we see it in every single control, we see a visual word form area, but in the 2 patients we don't. And then when we do a group analysis, we kind of just confirm that same thing. So like, here's the visual word form area in the 10 controls, and this is the region where the patients differ from the controls, where the patients have less of a difference, and it just maps exactly onto that visual word form area. But my favorite part of this study is actually this part, because I showed you guys several times that selectivity gradient concept. And it turned out we could identify that selectivity gradient also in every single one of our controls. So here's 3 representative subjects. And whenever a neuroscientist tells you that they're showing you a representative subject, it means that they're showing you their best subject. So here's the 3 best subjects. But they are representative in the sense that all 10 show essentially this pattern to different degrees of messiness. You see, what we're seeing here is the ratio of the false font response to the word response, right? So like, if they're both equal, then it's going to be close to 1 or 100%. But if the false font response is very small compared to the word response, then that ratio becomes smaller, and that's plotted in blue. So you see, as you go in the left hemisphere, as you go anteriorly, you get that gradient where it goes from red to blue, showing that there's kind of this emergence of selectivity. As you progress more anteriorly, you start to get more and more differentiation. And it doesn't happen in the right hemisphere. Here's all 10. As you can see, they're identical to those 3. And here's the 2 patients. This is the first guy. And what's striking is neither of them has that nice pattern of developing selectivity. The first guy kind of has some patchy stuff that happens, but there's no anterior to posterior gradient. There's just these kind of little blips here that probably don't amount to much. And the second guy doesn't really even show much difference between seeing the blocks of words or false font strings versus resting condition. So he doesn't even have color in his for the most part, because his brain is actually even more dysfunctional. But I find in many ways the first patient to be more fascinating, because his alexia is so pure and his brain looks so normal in so many ways. I mean, it's activating for both the words and for the false fonts, but all that's different is that it fails to develop that selectivity. So that's kind of, this essentially confirms our hypothesis that progressive alexias are just like, alexia caused by stroke, and that they are involving dysfunction in this visual word form system. But whereas a stroke involves just destroying the thing and having it not function, this involves some kind of failure to develop selectivity in that successive sort of path of steps. So that's the end of the peripheral part. And I think maybe I could ask for questions at this point and then go on to the central part, which is less of the talk. Like, this is probably like 3/4 of the way through the talk. So should I ask for questions about the peripheral part, or should I? Yeah. Does anybody have anything you're dying to? So let me talk about what happens after you get to your abstract word form and your visual word form area, when you have to map from that onto phonology or semantics, depending on what you're doing. The theory the sort of big picture theory that we have of this, from many decades of research, is that there are at least two pathways involved, and probably three. But I'm just going to kind of keep it simple at two. So there's a whole word or lexical mechanism. So to take a word like so, which is irregular, we can only read that correctly by some kind of lexical representation that tells us that this particular word is pronounced so and not su. Then there's a sublexical mechanism that takes the letters takes the graphemes and converts them into phonemes and applies things like rules about what e's do to vowels and so on and so forth. So both of these must exist in all of us, because we can read words like so, and we could read words like, blit. If I were to write it down, you guys would have no problem pronouncing it, right? So we know that we have both these mechanisms. And when I mentioned that there's probably three roots, I'm referring to the whole word root, because some people think that you can go straight from so to a semantic representation and then to its pronunciation, but there's also evidence that you can go directly from orthography to a phonological representation without access to semantics, because there are patients that can read irregular words correctly without knowing what they mean. Only a handful of patients have ever been documented, but there have been some very reliable studies that have shown that. So, and no pun intended, we wanted to look and see whether we could see evidence for this basic arrangement in degenerative alexias, where we would have, so we've gotten kind of, to the visual word form area, and now we're kind of hypothesizing that whole word mechanisms involve a further path through the temporal lobe, where sublexical mechanisms involve a path up through the parietal lobe and into the frontal lobe. So we looked at patients that have what's called, well, in this talk I should call it surface alexia, and this is an example of this. Okay, so this is, you guys I'm sure can see the pattern. This lady cannot read exception words, but instead she overgeneralizes them based on their spelling, and she does it to such a profound degree that she even produces a velar fricative for yacht. Did you guys hear that? And she is a native German speaker, as it turns out, which is why she has it in her inventory at all. But I mean, her English is perfect. I mean, she learned English at age 10. She's been speaking English her whole life as her primary language. But somehow, the CH just, she read that as a velar fricative, which I'm sure it was at some point in the past. So, you see that she does fine with the words that are regular and badly with the words that are irregular. In other words, she has a selective deficit of that ventral path. We can see, let's see her read some pseudo words. So she's excellent at reading pseudo words. So what we'd hypothesize is something like this, right? She's lost access to that whole word lexical pathway, so the so pronunciation is no longer available, and she's forced to overcompensate with the only pathway that's left, which is the sublexical one, and so she's going to pronounce this as su. And this lady her syndrome is called semantic dementia, and I talked about these guys in another context in my talk here, which was apparently 3 years ago when I was looking at my CV. Well, at least it was in 2011. So these semantic dementia patients always pronounce the word Sue as so. So as Sue. Always. It's like you could use it as a one-word test for semantic dementia. You show them the word so and ask them, what does this say? If they say Sue, it's like, okay, you've got semantic dementia. You're diagnosed. Okay, so we wanted to look at whether we could find evidence with functional MRI for a switch between using this pathway and using this pathway in these patients. So we made them read regular high-frequency words, regular low-frequency, exception high-frequency, exception low-frequency, and pseudo-words. Frequency is being modulated as well because a lot of the time in the milder patients, they fail, especially with the low-frequency exception words. They do better with the high-frequency ones like come and one and stuff like that you don't even think of as being irregular. Okay, so here's the behavioral data. Controls, they can read everything just fine. Semantic dementia patients, they're really good at regular words. They're pretty good at pseudo-words. They start to be bad at high-frequency exception words, and they're terrible at low-frequency exception words. So that's the group average, like 25% or so. This is their pattern of atrophy. It's temporal, right? So that's kind of where we get the hypothesis that this is going through the ventral region. But what we really want to show is with functional MRI, can we show that compensation of going through that other track, going through that other route instead? And I'm going to skip that. So the first thing that we noticed functionally was that in the ventral kind of path, these patients had less activity than the controls. So just across the board, not kind of in a condition-specific way, but the controls show a certain level of activity, and these patients show less activity in this ventral reading region. And if we look at where that is, this is just control data in color showing the areas that are activated for single-word reading and reading out loud, and patient atrophy in green to blue. And you can kind of see there's basically two overlapping regions, right? This is essentially the visual word form area. So the atrophy is extending back into the visual word form area, almost, maybe not quite. And then superior temporal kind of region. So those regions, when we look at the patients, you see that activity in the patient, so this is now the functional activity in the patients. You can see it doesn't extend down as it should into those atrophic regions. So that just kind of shows that the atrophy causes functional abnormalities in those ventral or lower pathways. Now this is the real cool part. We wanted to see what would happen in the dorsal pathway, right? So in controls, going up through the parietal lobe, when they're reading pseudo words, they activate this region in the left parietal lobe, but they don't activate it at all when they're reading low-frequency exception words like choir, right? So if you're reading snite and hance and smode, you show activity there if you're a control, but you don't need that to read choir and so on, because choir and yacht and kernel don't rely so much on the sublexical path. So there's that contrast in controls, but in our patients, they recruit that area for both conditions. So they have it for pseudo words, which they're good at, just like the controls, but they also show it for reading the low-frequency exception words, which they are over-regularizing, right? So it's almost like they're reading them like they're pseudo words, which is basically how you would interpret it, but now we can see what is the neural correlate of that. Really interestingly, when we looked trial by trial, they don't make an error on every single trial, right? So sometimes they get so we're looking in that left parietal region in the patients. When they read it correctly, they don't show any signal. When they over-regularize, they show more signal. So even on a trial-by-trial basis, if they're going to get it right, they're going to go through their ventral route, and if they're going to get it wrong, they're going to go through their dorsal route. And so it really shows you something about what this inferior parietal region is doing, i.e. being involved in the sublexical reading route. So that's the theory of that. And then the very last thing I want to show you just really quickly is whether we have the other side of this dissociation as well. And for this, I'm going to refer to two studies by my colleagues, neither of which I was personally involved in, to see whether there are patients that can do whole word reading but can't do sublexical reading. And the question is, do they have the opposite pattern of degeneration? And the answer is probably yes, because so this is one study. Actually, I'll just they show essentially the same things. I'll just point to this one, which is by Maya Henry and colleagues. Maya graduated from U of A in, I think, 2009 or 10 or so. And this is basically a map of where atrophy was associated with reading of pseudowords and exception words. What she found is that patients that had ventral atrophy were impaired at reading exception words, just like the ones we've just seen. But also what she showed that we don't have in my data is that patients with dorsal atrophy were impaired at reading pseudowords. So you kind of have that nice doubled association among the degenerative patients. Kind of putting it all together, just from neurodegenerative data alone, we can kind of see evidence that we have this pathway that kind of goes through, and moving anteriorly, initially bilaterally, and then left lateralized, as you go from a sort of visual representation to an abstract visual word form, and then from there you go dorsally using sublexical mechanisms, and you go ventrally using lexical mechanisms to get to your phonological and semantic representations. I mean, it's kind of very big picture-y, but I think that that's the basic outline. And I'd say broadly the progressive alexic data match pretty well with all the other sources of information, in some cases being more refined and in some cases less so. So just to finish up, I'd like to thank all of my co-authors that I already showed you guys pictures of, Grant, other people that have helped out, and especially the two guys I talked about the most who were really patient with being in the study. And thank you all for listening.